So is it okay to start?
नहीं 2 मिनट वो कह रहे हैं तो
Okay, sure.
ठीक है सर, कंटिन्यू करें।
Bismillahirrahmanirrahim. In the name of Allah, the most gracious, the most merciful. Assalamu alaikum, everyone. I'm Asma Chima, and welcome to Apna Merit COVID-19 webinar. Today we have our speaker, Dr. Shahid Rafiq. We have our panelists, we have attendees, and I would like to request all the attendees to introduce themselves in the chat box, and they can post their questions in the Q&A box that we will address at the end of the talk. I will request everyone to keep their mic muted during the talks to avoid any disturbance. Today, our speaker is Dr. Shahid Rafiq, who is a neurologist and a stroke director and Apna Merit chairperson as well. Our goal is to complete this session on time and would like to be more productive for everyone. And I will welcome our speaker, Dr. Shahid Rafiq, and will request to introduce himself. Thank you, Dr. Shahid Rafiq.
जी अस्सलाम वालेकुम I'm Shahid Rafiq. I'm a vascular neurologist. I have my board in neurology as well as vascular neurology, which is stroke, and sleep medicine. I have worked for past 14 years in just north of Washington, D.C. in Maryland, in Frederick, Maryland, and Silver Spring and Germantown, Maryland, in two healthcare systems. One is Holy Cross Healthcare and other is Frederick Healthcare System. And in both systems, I'm the director of neurology and stroke for the past 14 years. And that's my experience in creating stroke programs and developing them and keeping them in the Get With the Guideline Honor Roll Gold Plus Award and maintaining the door to needle time in the elite range. So when we started this webinar about what now, 27, 28 days, 30th of March, we started, 31st of March. I was just there as a chair of Apna Merit and support of the team. And every day I was thinking, you know, nephrologists are coming after. So obviously we started with ID specialists, then pulmonologists, intensivist. Then we had some cardiologists. Then we had some nephrologists. I was thinking neurologists are not coming. We are just outside in this COVID system, COVID disease. And suddenly in the past 1 week from 24th of April, this came right in the center of this whole COVID-19 disease by the Washington Post report. So I will start that. Let me see why it's not moving forward. Oh, I should say play from start. Okay. So Washington Post reported on 24th of April, and they had a big report, mainly coming from Mount Sinai Hospital in New York, where they had seen 5 cases of young, less than 50 years of age, patients who came with stroke and later was found to be positive with COVID. So they started talking about this within their colleagues and found out that in the past 2 weeks, they had 5 cases. Although in the past year, every 2 weeks, they were getting less than 1.7 young patient with stroke. But in the past 2 weeks, prior to 24th of April, they had 5 stroke in young, and they were devastated stroke, big stroke. So that's why then they started talking, and they published in New England Journal of Medicine as a series case report of 5 patients. I think it was published on 28th of April. So that's how it it suddenly got into the big news, and NPR ran it, and other media systems and TV programs. So, but in the meantime, I just wanted to mention that we also, in our system, I saw our team actually saw, I was not doing that much inpatient, I was doing more outpatient, and our colleagues in our group were on call in the past 1 month. And the last week was, including today, was the first week that I covered the hospital. So I talked to my team, and we already had 2 cases in Frederick Hospital and 4 cases in Holy Cross Hospital in the past 2 weeks. But I reviewed those cases, but there's a stark difference. One, so for example, this case in Frederick Hospital of patient KC, a 58-year-old gentleman who had past medical history of hypertension, came with left-sided weakness, which started 2 days prior to his presentation to the hospital. It was progressively getting worse. That's why he came when he was falling recurrently and could not get out of the bed one day, and then came. He had other symptoms, which was fever, loss of smell and taste, and diarrhea. And his wife worked as a nursing assistant in a skilled nursing facility here in Frederick, where apparently some of the residents had tested positive with COVID-19. And so we had CT of the head done, which showed old bilateral ischemia, but particularly one new area of ischemia in the right corner radiata in the periventricular region. The CT angio was done, which was limited. Initially, it reported a stenosis in the left carotid, but we confirmed it with the carotid ultrasound and found that it was mild stenosis, less than 50%. Patient also had bilateral pneumonia with COVID-19, and he was started on IV antibiotics. Amlodipine was given with the for the blood pressure after permissive hypertension period of 2 days. And initially he had mild acute kidney injury, probably because of the prerenal ischemia, but that resolved. So then this was the CT scan of the patient. You can see here, this is the hyperdensity in the corner radiata on the right side in the frontal region. MRI could not be done. Most of the patients, I will let you know, I think when the Mount Sinai raised the alarm, now then everybody is doing MRIs, but previously it was thought that because coronary radiata, this COVID patients were infectious, and so the MRI will, it will go into that, and then if somebody else comes in MRI, that can get infected. So to avoid that and to avoid a lengthy disinfectant process between the patients, they were not doing MRI. And once you do not do, when you do not do MRI, you can miss a lot of, like this one appeared, but a lacunar stroke, particularly in the posterior circulation, will not appear. The new stroke within 12 hours will not appear. So you can miss a lot of cases. And a lot of cases probably did not get even a CT scan, because if they deteriorated quickly, and everybody is concentrating on chest X-ray and CT scan of the chest, and pneumonia and ARDS, and they are intubated, I think hardly everybody will be saying, okay, let's look if in addition this patient has a stroke or not, because the patient is serious and critical anyway, and the whole team is focused on that. So probably we missed a bunch of cases, and Mount Sinai team actually mentioned that in New York City, a lot of um, the firefighter, when they had a call, they went and actually the patient had died by the time they went, or they were called because the patient died, and they picked up dead bodies from many of the victims' homes, and they were wondering how many of those might have had stroke. So a lot of numbers could have been skewed by the situation that we were in, and the scare and the you know apprehension and curiosity and focus to the lungs and kidney and heart later on probably missed a lot of brain issue, including stroke. So this is the second patient also on 426 in Frederick Hospital. HV was 85-year-old and Caucasian gentleman, right-handed. He presented with alternate mental status, recurrent falls, outside TPA, and thrombectomy windows. CT brain with evolving left frontal stroke, right facial and upper extremity and lower extremity moderate weakness, about 4-5. And that later on in, I think, couple of days, progressed to flaccid paralysis. No cough or pneumonia on chest x-ray. So he did not have a lot of typical COVID disease symptoms. History of bipolar, he was on Zyprexa and lithium. Lithium level was checked, it was normal. He also had baseline dementia, uncontrolled diabetes with hemoglobin A1C of 11.6, and failure to thrive, hyperlipidemia, and sleep apnea. So as you can see, the patient was pretty sick. Here we could not get the MRI, and he quickly was, the end of state and palliative team got involved, and I think they are going to declare him a hospice and admit him in hospice. The last one, I think I got two from Holy Cross. One is this young man, 45-year-old right-handed gentleman, coming with hypertension and diabetes, which was uncontrolled because of the non-compliance, some insurance issues, some his own youthfulness, which he didn't care to take them regularly, the medicines. And he presented with imbalance and left-sided numbness and weakness going on for a few days. He was out of the window, I would like to remind here that even in Mount Sinai series, they noted that a lot of patients came with a delay, particularly their first patient, the young woman who came, I think, about 1 week after her symptoms. And the reason was they didn't want, they were young, they didn't want to go to a place where the COVID was flourishing, so many patients in that hospital with COVID, particularly in New York City. So they did not want to get themselves infected while they were actually infected at home. And they delayed the care and went with a delay. Because of this, this is another kind of interesting situation where generally we say the stroke patient to call 911 immediately as soon as the symptoms start, which seems like stroke-like symptoms. So anyway, in this young guy, the MRI showed right basal ganglia and thalamic lacunar stroke. LDL was moderately high. D-dimer was mildly high, 356. MRA was normal, and SARS-CoV-2 was positive. He was treated with symptomatically and supportive treatment, discharged after a few days. And this was his MRI. You can see here this small lacunar stroke. Now, interesting thing about these cases, I think these were the cases that I picked up. and how they differ from the series of Mount Sinai, five case series of Mount Sinai, is that the cases in Maryland that I came across, or my team came across, was not very spectacular in the way, as you can see, that these patients have either they were old or they had risk factors, like even this 45-year-old had hypertension and diabetes, both of which were uncontrolled. And so obviously, no wonder if they had a stroke, number one. Number two, the strokes were lacunar, posterior circulation, periventricular. These are not your typical cardioembolic or embolic stroke, and or LVO, as we say, large vessel occlusion strokes. And those strokes, because there's a proximal vessel occlusion, present with a bigger deficit and higher NIH stroke scale. So while this was good that when I asked them, oh, yeah, we had COVID-19 and stroke patients, I said, okay, where are those? So I reviewed them, and so, but these were just, I think, like, I would say, you can say maybe coincidental and not from COVID-19. Maybe they had their uncontrolled and high age reason for having a stroke, and coincidentally, they also had COVID positive status. But the interesting thing from this Mount Sinai series is, which as I mentioned, was published as a correspondence COVID-19 cases series in New England Journal of Medicine, is that that they were young. They were noted in a 2-week period from March 23 to April 7, and a total of 5 patients, and all of them, they were less than 50 years of age. So that's number one, that distinguish them, because stroke in young is not that common, although we are seeing it more and more because we are detecting it more and more by utilizing MRI early on. Everybody now, if a neurologist will see the patient will get an MRI of the brain. So we're detecting it more, but still it's not the same as above 50s, above 60 years of age. So these patients had one common denominator, that they were less than 50 years of age, and all tested positive for COVID-19. And like I previously mentioned, by comparison, in Mount Sinai, their usual 2 weeks number is 0.73, the stroke in young. So as compared to that, it was like 6-7 times more incidence. And then the other thing was that these patients' NIH stroke scale median was 17. Now, this is what distinguishes it. So although it's a busy slide, but let's quickly go through with this, and then we'll go to the question and answers. That when you see the age in these 5 patients, you see that the highest age is 49. So 44, 39, 37, 33. And this was the lady that I was talking about. She came after 1 week, this 33-year-old lady. The gender-wise, 4 were male and 1 was female. Then this is important, that 3 had some risk factors under undiagnosed diabetes. So that was 1. Here it was mild previous stroke and diabetes, and hyperlipidemia and hypertension. but not much. Nowadays, as you know, that hypertension is starting earlier and earlier in 30s. So you would find that. Then they were not on any medications except this patient number 5 on aspirin and atorvastatin. NI stroke scale, like I mentioned, was very high. This is typical of LVOs. And after 24 hours, most of them remained high at last follow-up on 14 days. Some of them got better, 5 and 7. Other remained high, and one was intubated. And then most of them got discharged, but one remained in stroke unit at the time that they're published, and one was in ICU. And mostly the obviously these symptoms will be big if your NI stroke scale is 19 and you have hemiplegia on the left side, you'll have facial weakness, gaze preference, monogamous hemianopia, dysarthria, and sensory deficit. Same thing with the other patients. And of course, then some of them had reduced level of consciousness. So and the mechanism, obviously these mostly the MCAs were involved. In this patient, 33-year-old, right, ICA was involved, but usually middle cerebral artery, middle cerebral. In this 39-year-old male, there was posterior cerebral artery. So usually LVOs and cardioembolic strokes go to middle cerebral artery because that's more in line with the ICA, internal carotid artery. Now, imaging, obviously they did everything, CTA, CTP, and MRI in most cases. Here it was not, the CTP was not done, but because the patient was already out of the window for TPA, so they, I think, quickly took them for retrieval. Now, COVID-19 patient symptoms, in one there was none, but others have some. Two had not done. Sorry, let me take this. I'm on call also. Sorry.
All right, everyone. So we have few questions as Dr. Rafiq is on the call as well today. So let's go over a few questions we had from the last time. Someone asked about the ARBs and ACE inhibitors. So there's one study just published yesterday on May 1st in New England Journal of Medicine, renin, angiotensin, aldosterone receptor blockers and risk of COVID-19. So that study shows there's, so they had a large study, population-based studies. The use of ACE inhibitors and ARBs were more frequent among patients with COVID-19 than among controls of their higher prevalence of cardiovascular disease. So however, there was no evidence that ACE inhibitors or ARBs affected the risk of COVID-19. So this is just published as of yesterday in New England Journal of Medicine. This was one of the questions I received from the last time. So let me go over other questions that we can address by the time Dr. Rafiq will be back. All right. So let's see. I'm gonna say anyone in the panelist have any comments, any their experience with the COVID-19, if they want to share with us, you are more than welcome. You can unmute yourself, you can introduce yourself, and then any cases you want to discuss or any experience you want to share with us, you are more welcome. All right, so there's one question about the anticoagulation. So let's go over. As Dr. Shahid Rafiq was mentioning about the large vessel stroke as presenting feature of COVID-19 in young patients, so this study is also published in New England Journal of Medicine on April 28th. And in that study is already discussed with you. So I'm going to just go over pretty quick. If you want to review that, it's also on the New England Journal of Medicine. It's online. If you want, I can share with you in the chat box, so you can review yourself as well. So Dr. Shahid Rafiq is back. So let's go back, Dr. Shahid Rafiq. Thank you, Dr. Shahid.
Okay, sorry about that. That was also a stroke, but not an acute stroke. Anyway, so I think we are coming to the end. And as you see, the labs not very impressive. Just the white cell count, platelets, as you can see, PT, PTT in some borderline high. The D dimer was not exactly. So no, sorry, in some patient, you see this 2,000 and 13,000 and 1750. So that was impressive. Ferritin also in someone, acute reactant. So that was the situation. And when this report came, then obviously two other institutions also said, like Emory from Dr. Cooper Smith from Emory said, we also had seen some cases in Atlanta, Georgia, in Emory Hospital, and then WashU in St. Louis also, Dr. Osborne came up and endorsed that study from our case reports from the Mount Sinai. So then obviously, like I said, it came into main limelight. The mechanism is, again, cytokine storm syndrome. They're saying damaging the endothelial surfaces of the arteries and generating the clots there, or just the hypercoagulability with the elevated level of D-dimer and severe platelet reduction. These can be some of the mechanism. And these are some of the things that so a lot of these patients have anosmia, so that can be early sign because as you can see, if olfactory bulb is getting involved as we enter vagus nerve and bloodstream, and then here, what this storm does, that it increases the permeability of the blood vessels, and so then obviously neurons and other support cells in the brain will get affected, and then it can leak into the CSF, and the PCR can be done on CSF in addition to the blood. And this is obviously, most of us know how this RNA virus replicate after attaching to the ACE2 cells. And then last slide is again the same. Some of the ways, even if initially they're different with ACE2 immune injury or direct infection, but it can cause demyelination or increase IL storm, anaerobic metabolism, or SIRS, and major histocompatibility complex. But end result would be that either you get a stroke, you can get viral encephalitis, or you can get infectious toxic encephalopathy. These are the three major CNS symptoms or presentations that we have seen. We have not seen an neuropathy or other. I would say I didn't see even demyelination as well for now, but obviously the jury is still out, and we will be looking at it more. So with that, I will end my presentation and welcome discussions and questions.
Shahid Bhai, could I say something?
Ji, Dr. Ghafoor.
Sir, excellent presentation. You see, we want to discuss it in prospect of in keeping Pakistan situation in view.
Ji.
Obviously, I work in a big teaching hospital, but we have an MRI. The worry is, you see, obviously, with our limited resources, exposing that machine or that staff to having an MRI, would CT help us? One. Second, would clinical, acumen be more appropriate for us? Keeping in view that we have shortage of PPEs, we have, fumigation and things like that, and we still run an emergency service on day-to-day basis with other illnesses.
Right. So I think this is a very pertinent and important question. Amir, like we have been saying before, that every solution should be considering the ground realities and I think I agree with you that because my concern when these reports came, really first thing that came to my mind is was that if these are major strokes, like LVO strokes are major stroke, large vessel occlusion will cause a major stroke, right? And unless you quickly go in, do the TPA and do the clot retrieval, which I think very few centers in Pakistan are doing the thrombectomies. And they are also doing very, very few. So unless that is done, the patient suffers from a MCS stroke, which is a large stroke. How even you can anticoagulate quickly that patient, because that's a big contraindication. We do not anticoagulate that patient up to 2 weeks or more, because that's a fresh wound in the brain and that will bleed. However, if we see that in addition patient has pulmonary embolism or MI, or cardiologist tells us, pulmonologist, that no, they need to start the anticoagulation to save the patient's life, then obviously talking to the family that yes, the outcome can be worse than saving and patient can bleed to death, then it can be started with a low dose heparin without a bolus. That's how we do it. So my point is that yes, it is okay to do CT scan later on, if just to know that there is another comorbidity in addition to pneumonia, and that patient may not get better. But obviously the treatment, like out of those 5 case series, 3 were treated with antiplatelets. So meaning that you start aspirin and do the other workup, maybe other risk factors, try to control them. Because obviously clotting from the COVID-19 disease process may not be controlled at that time. It's just the nature of the disease. So yes, I would say that every center should decide how much focus they will give to diagnosing stroke, which can be diagnosed with clinically also. If in that center, like I know LRH has neurologists, so they can diagnose with their clinical exam.
Because Shahid, we've had the largest amount of deaths in in context of Pakistan, KP province. We have the largest in the province, and then the 80-90% of the burden is being taken by LRH. There are various reasons for it. Obviously patients come to us from all part of KPK, which is far flung, and they're moribund, but we haven't seen much neurology. Now that might be that we are not looking for it.
Right, the same thing here. We didn't look for it. So what is the reason, Amir, for KPK increased risk of?
Yeah. I mean, Shahid, there is various reasons. You see, obviously our catchment area, we cover Afghanistan, we cover mountainous areas of Pakistan. Everybody wants to come to Peshawar and LRH. So there have been quite a few incidences in which the patients have been literally brought in gasping, and before even they come off the ambulance, they've died. So that all adds to our mortality, although to be fair to us, it's not our mortality because the patient is what we call, here they call it, we call it death on arrival, so DOA, but you have to be careful. In Pakistan, DOA is used for date of admission also. So that's one. Second, for some reason, I think Mariam might be online, we're seeing more cardiac complications than neurology. For neurology, and obviously respiratory, I'm not sure, maybe we're not looking at it, or the patients we are getting are not young. At least up till now,
Right.
we haven't had young people. You see, that's one of the things which we've noticed. But
Right.
obviously, we dissect and take advice from folks like you as we go along.
Sure.
Right. Thank you, Dr. Amir Khan. Thank you, Dr. Shahid Rafiq. It was really great talk. It was really informative. Before moving towards Q&A session, I would like our panelists to introduce themselves one by one, and they can have the comments and questions so we can address one by one. And of course, we have a lot of questions in the Q&A session. And I would like to go one by one on the panelists so they can unmute themselves and introduce. So first of all, we have Dr. Hassan Ahmed. Okay, Bushra Ali, yes, you can go ahead.
Okay, I'm Professor Bushra Jamil. I work at the Aga Khan University, and I'm also the president of Medical Microbiology and Infectious Diseases Society of Pakistan.
All right. So then we have Dr. Amir Khan, we just spoke to, right?
Yes, obviously, my name is Amir Ghafoor Khan. I'm one of the professor of gastroenterology at Lady Reading Hospital, Peshawar.
Right. Thank you. Dr. Iqbal Ahmed.
Assalamu alaikum. Iqbal Ahmed from University of Texas Southwestern at Dallas and Children's Medical Center of Dallas. I'm a pediatric anesthesiologist and associate professor in the university. Thank you.
Thank you. Dr. Kaleem Ahmed.
Assalamu alaikum. Kaleem Ahmed. I'm a pulmonary critical care and sleep medicine. I'm in Maryland. Thank you.
Thank you. Dr. Mariam Morton.
Assalamu alaikum. I'm Mariam Morton. I'm a staff cardiologist, non-invasive at Loma Linda, California. And to answer Dr. Amir's question, yes, we do see a lot of ischemic heart disease and people presenting with acute coronary syndrome. We look for EKG changes and we also look for enzymes, and we manage them clinically. We don't really take them to the cath lab and do just point of care ultrasound as much as we can, and only when it's indicated. Thank you.
All right, thank you. Next, we have Dr. Shamsa Humayun. Dr. Shamsa Humayun.
Can you hear me?
Yes, please. Go ahead.
Assalamualaikum और सबसे पहले रमजान मुबारक सबको. I'm head of gynae department at Fatma Medical University, and I'm vice president Society of Obstetricians and Gynecologists Pakistan.
All right, thank you. So now let's move towards the Q&A box session. We have Imjad Hussain who posted the question, and I would like Dr. Imjad Hussain to unmute himself and ask yourself, Dr. Imjad Hussain.
Yeah.
You could read it.
Assalamu alaikum. Ji. I'm Dr. Imjad Hussain, and I've been posting questions for a while. And there was a pause for like 7 or 8 days because of the Ramadan here. And I'm a family physician from Pakistan. I basically practice here in Jhang. And I think I posted a lot of questions. So I won't take much of your time here.
Sure. You can go ahead with your question one by one, and we'll see how many we can address. We are almost going towards the top of the hour. And of course, I understand there's iftar time in Pakistan as well, but we'll try our best. So you can ask yourself.
Yes. Okay, sure. So I was going through a recent, actually, Dr. Danish Bhatti, he posted something on LinkedIn, and that says like Parkinson's disease could be the next on the list of COVID-19 patients that have a propensity for aggressive course of disease. So I was just wondering if there is some sort of dose adjustment or some sort of precaution that we need to do in terms of management of Parkinson's disease patient, and like modifying their anti-Parkinsonian agents?
So, Imdad, I am not aware of how, did he mention what would be the mechanism of how the Parkinson's disease will get worse? Like in stroke, we actually I was not surprised when we were seeing that there were a lot of hypercoagulability. We've been discussing in these webinars for a while that there are a lot of clot formations and pulmonary embolism and catheters getting clogged. And so it was no surprise that we started finding the strokes because of those, embolic phenomenons that were already going to lungs, so now they're going to brain. But I am not sure how the Parkinson's disease, which we already do not have a good sense of, the starting and the etiology and a lot of debate and murkiness there, will get worse with the COVID-19. So obviously it will depend on the mechanism. If say, for example, somebody is talking about if the elderly people are at home, isolated, and they are not going out or walking or getting much exercise, they get deconditioned, and that could be one way that Parkinson's disease can get worse. So that the intervention or treatment for that would be to do more exercises at home, whatever they can do. So not knowing what reports he was alluding to, it would be hard to say. But obviously, as a general rule, because this is a new disease and because we know that it is affecting each and every organ in the body, and now including a brain. So after stroke, obviously, we may see neuropathies, we may see nerve problems, we may see basal ganglia. That's another thing that comes to mind, that if the stroke will involve basal ganglia or center of the brain, then maybe the Parkinsonian symptoms can get worse. Next question.
All right. Thank you, Dr. Shahid Rafiq. So we have next Dr. Inam Khuda. Can you please unmute yourself and ask your question? All right. So Dr. Inam Khuda, he's asked about, I think he's not there, if the mechanism of stroke from...
Hello.
Okay, you're there. Okay.
Hello.
Yeah, please go ahead.
Yeah, I'm Dr. Inam Khuda. I'm assistant professor of neurology in King Fahd Hospital in Saudi Arabia. So basically, I'm an epileptologist, and we don't really see many of the cases here in Saudi Arabia. Just out of my own interest, since we think that the reason for stroke with COVID-19 is basically a hypercoagulable state, so don't you think that anticoagulation would be a better choice instead of antiplatelets in these patients?
Absolutely, Dr. Inam. Anticoagulation would be the first choice. I think the reason they, out of 5, they started 3 on antiplatelet was their risk factors, where thrombotic mechanism could have been involved as well. But if clearly somebody does not have other risk factors and it's an LVO, and it seems like that the patient was hypercoagulable, for example, with the markers and D-dimers and all that, absolutely the anticoagulation will be the first choice. Like I said before, however, that the timing of anticoagulation would be a problem, because as you know, with bigger stroke, in the bigger stroke, we do not start anticoagulation. We do not do heparin or Eliquis or others because of the risk of bleed in those strokes. But it will be the first choice.
Yes, thank you very much.
Thank you. And Dr. Mariam Morton has a question. Dr. Mariam Morton, can you please unmute yourself?
Yes, thank you so much. I was just wondering if there's a pattern of CNS finding with COVID-19 patient with stroke. And do you see generalized muscle weakness with patient with COVID-19 infection? Is it muscular or is it neuromuscular?
Right, that's a good question. Like I said, we have not seen so far any cases with neuropathy, so it will not be neuromuscular. I think it would be muscular in terms of generalized fatigue, generalized weakness due to the disease burden from, pneumonia or whatever they're going through, fever, fatigue, malaise. But with stroke, it will not be a generalized weakness. It will be a focal weakness. So we have not seen a, I would say, neurological generalized weakness.
Thank you, Dr. Shahid. So next we have Dr. Muhammad Salim. Please unmute yourself and ask your question. Dr. Muhammad Salim.
Hello.
Yes.
Go ahead.
Yeah.
Right.
Assalamu alaikum, Janab.
Yes, sir.
Very nice presentation, Dr. Shahid Rafiq and Dr. Muhammad Salim Khan from Kotli Azad, Jammu and Kashmir. In these stroke patients with COVID-19, did you isolate novel coronavirus 2 from their nasopharyngeal swab or from CSF?
No, it was in the case series, it was from nasopharyngeal swabs. I don't think we did a LP on anybody.
Yeah, thank you.
Right. Thank you. So next we have Dr. Muhammad Naeem. Please unmute yourself and ask your question.
Assalamu alaikum. Dr. Shah sir, thank you very much for your donation for PPEs for PMA Gujranwala.
Oh, okay, sir. Good. Thank you.
Second one is that we are thinking about coagulation factors directly impaired in cases of COVID-19. But is there any other situation in which the coagulation factors from the base, that is the liver, there is derangement in the liver, and the other factors which we think that other enzymes are also impaired in this case?
I do not know, so you mean that because as far as I think that if liver is damaged or involved, wouldn't it be more bleeding or thinning of the blood? The PT and PTT prolongation, especially PT prolongation. But I think any other panelist can.
Yes, I think you're right, Shahid Bhai. Obviously, if the liver is involved, the QAG screen would be deranged anyway. If the liver is involved, vitamin K, vitamin K related factors and these things would be deranged, fat soluble ones.
Okay. So will that lead to more coagulation or hypercoagulation or bleeding?
It would lead to bleeding. If it's like, if you look at liver disease, we get, the blood gets thin and patients bleed. So you have to reverse it by giving vitamin K.
That's what I thought. Yeah.
Naeem Saab, did you get the point?
Yes, sir.
Thank you. So next we have a name showing up over here, Glexi 830. Can you please unmute yourself and introduce yourself and ask your question, please? There's a name popping up, Glexi 830. I don't know the name. Can you please introduce yourself and ask your question? Your question is in the Q&A box.
We can move on to next one.
Sure.
Dr. Chima.
So sure. Yeah. Next one, Dr. Muhammad Salim is asking again. Have you seen COVID-19 with encephalitis, Dr. Shahid Rafiq?
Gigi, that actually was the first manifestation or first involvement of the central nervous system in COVID-19. But again, my point at that time was that we see it all the time when patient comes, or especially particularly elderly patient, come with pneumonia or UTI or any, and some of them, if they already are developing mild dementia, just being admission, we call it hospital-related dementia or delirium, that they will have alternate mental status, and of course, like encephalopathy. So, so any infection has the potential to involve the brain and causing what we call metabolic or toxic encephalopathy. So it may not be related, just it's not something that is unique to COVID-19. But because COVID-19, of course, is an infection and can involve, pneumonia and ARDS and then kidney failure or liver failure. So then as a result of those, the brain will get involved and will cause a metabolic/toxic encephalopathy. Thank you.
Thank you, Dr. Shahid Rafiq. So we have a couple of other questions, and almost we're at the top of the hour. So I think we will take a last question, and then we'll save other questions for next session, and we can have a just specifically Q&A session so we can address all the questions. So Glexi 30 was asking, there are 3 questions he asked about. I don't know. Anyways, so he asked about, first of all, use of anticoagulant, corticosteroids, anti-inflammatory drugs are useful in these patients. So I think he meant to ask about using corticosteroids, anti-inflammatory, and are useful in the COVID patients, not specific to the stroke patients. So I would like to address, yes, we are using the corticosteroids and anticoagulants. We are using as a prophylactic dose at this point. Yes, we are using it. So secondly, he asked about rheumatoid arthritis have less probability of getting COVID infections. So I can address this one as well. This one is related because patient on rheumatoid arthritis taking hydroxychloroquine or such drugs. So that's the reason they were having concerns. Maybe the patient on those medicines or having rheumatoid arthritis are less probable having COVID-19, but there is no scientific data available at this point that patients who have rheumatoid arthritis or taking hydroxychloroquine having less probability. So last one he asked about, Dr. Shahid Rafiq, I will refer it to you. The pathophysiology is reverted from pneumonia to stroke and thromboembolism. Is it pathophysiology reverted? I didn't understand this question. I don't know if you can address it.
Right. I think his point is that the pathophysiology is expanding. So I would say, yes, it's expanding in terms of whether it's expanding or we are seeing more role of this storm that is injuring many organs. So for example, in this case, it's injuring the endothelial lining and of the vessels that will lead to the clot formation, it is the disease itself is expanding into the mechanism where like hypercoagulability, which we have seen before as well, and damaging different organs. So like a new disease, which it is, we are still exploring and marveling on how many different presentation and different aspects and angles there are to this disease, and we're still learning.
Great, thank you.
Dr. Rafiq, Iqbal Ahmed from Dallas. And I have a comment and a question about the proposed mechanism. You kind of demonstrated in a graphic the various things, various derangements that can happen with theorized to happen. So we know from studies in the Netherlands and in Boston that 30% almost of patients in the intensive care unit, that's the patient population they measured, have ultrasound evidence of thromboembolism or thrombosis in major veins and in arterial lines and in major arteries. This was they discovered in patients who were otherwise would not have been picked up by symptoms. The issue with the with the 5 presentations from Mount Sinai that you presented, as well as your own patients, is that it doesn't appear that they were in the middle of a cytokine storm. Some of them had markers, and some of them, it was very variable. So the mechanism that the cytokine storm is leading to hypercoagulability or a DIC kind of picture doesn't really seem to explain the phenomenon. The hypercoagulability is probably an early phenomenon that normally is not discovered even before the cytokine storm is is kind of full blown with multi-organ dysfunction. So if you can comment on that
right, I think I agree with you, Iqbal, and obviously that they mentioned also that this sample size is very small, like 5 case series. And before that, even from China, when they mentioned 1 or 2 patients early on, they have not come up, or maybe at that time they were not looking at it, a large cohort of patients with stroke to understand really the true mechanism. So at this point, it's variable. Like you said, coagulability or clot formation in 30% of the ICU patients seems to be the primary mechanism, particularly in a young patient without any risk factors. So we still, I think, will see a lot of literature coming more from other centers and from maybe Mount Sinai about this.
Right, thank you. We have another question from Dr. Inam Khuda. He's asking, if the mechanism of stroke from COVID-19 is hypercoagulable state, then don't you think that anticoagulation would be a better choice rather than antiplatelets?
I think we just answered that question, that yes, that question was from Saudi Arabia, that yes, the anticoagulation would be the first choice. However, if the stroke is small, if the stroke is large, you cannot start anticoagulation without taking a risk of hemorrhagic conversion of that stroke. So while the anticoagulation is a first choice in a clear-cut cardioembolic or embolic thromboembolic stroke, the other risk factors, if the patient, stroke patient will have other risk factors that make thrombotic mechanism more likely, then obviously, and if the stroke is big, the first choice would be antiplatelets. But if it's a clear-cut clot mechanism, hypercoagulability, young patient without any risk factors, the anticoagulation will be the first choice.
Right, thank you. So we have addressed all the Q&A in the box right now, and I think we're already at the top of the hour. And panelists, if you have any comments, any questions, please unmute yourself and go ahead. All right, so let's wrap up over here. Dr. Shahid Rafiq, thank you so much. And again, I know it's iftar time, almost approaching in Pakistan. So everyone, again, Ramadan Mubarak. Thank you so much. Please, if you have any questions, keep sending us and we'll address in our next session. Thank you so much, everyone. Thank you, Dr. Shahid Rafiq. Thank you.
Assalamu
alaikum.
Assalamu alaikum.
Assalamu alaikum.